why patient comes to us, a lot of psychological impact. Even in our marriages, they have to remove the shirt in front of others. Even during death rituals of the parents, they need to remove the shirt in front of others. These are the few reasons they come to us for surgeries. And I don't want to give a double incision mastectomy scar or penalist mastectomy scar in these situations. And obviously, Indian skin won't scar well. Obviously, they have this kind of even a very well settled scar is not a good scar when they remove the shirt in front of others. So we try to avoid the scars in the severe grade gynecomastia patients, and we're trying to search for a solution for this problem. And this case came to me. I did a liposuction band excision, did a tight plastering. I removed the plaster on 4th day. I saw this patient. He's not happy because he wants to, want to become a bodybuilder because he lost a lot of weight. 40 kgs he lost and reached this position. And now after the surgery, I don't want to give a penalist mastectomy scar in the initial phase. Then I did only the liposuction band excision. So I don't know what to do immediately. I gave a little local anesthesia. I pulled the skin and sutured to the anterior axillary line. And when I removed after 5 days, it left a hyperpigmented. When I removed the suture, it became hyperpigmented, and still I'm not happy about the results. So finally, we ended up doing a penalist mastectomy, and this is the final results. And he became a bodybuilder. This is a photograph what we sent recently to me. So, but I'm not happy because though the final results are okay, but still we made him come so many times with multiple surgeries. So the major problem what I face is keeping the NAC in the lower border of the pec major. So we came up with a lifting plaster technique. We used a plaster to lift the areola superiorly and medially, and this is a technique. So we use a gynecomastia after the surgery. We cover the wound, and it is a medial lifting plaster. So stick only half of the plaster, then you pull it and medially lift the plaster, medially lift the areola. And this is superior lifting plaster. And same way we do the opposite side also. Make sure that areola both in the same level. Sometimes we go back to the post-operative room and check in the sitting position whether the areola is in the same position. If not, I readjust it on the same day because when it settles the other way around, it is difficult to change it. So, but of late I am seeing that there is no use of putting a medial lifting plaster because otherwise the areola is fully laterally deviated. No point in doing the medial lifting plaster, so we use only superior lifting plaster. So most of the time it's adequate because putting a lot of plasters, patients are not comfortable. So these are our publications, one in PRS Open Forum and the Global Open, and other in the AESURG Journal Open Forum. So the next common problem what we face is the seroma formation. So we use energy devices as well as power assisted. We feel that seroma is a very common problem in our population. So because of the seroma, a lot of other issues also happen. Superficial necrosis are common because of the seromas, and abnormal skin attachments are very common because seroma, in and around the seroma there will be an inflammation that won't allow the skin to regrade in an even way. So we end up in having this kind of abnormal skin attachments. So in the same way, I feel that reason for the greater deformity, especially in the grade 3 and grade 4, not removing the excess glandular tissue below the areola, it is basically the green mark area. That area only you need to be extremely careful. You need to, in fact, if you have a doubt, leave a lot of tissues. When you finish the surgery, try to adjust and try to remove a little more. Because that if you remove more in the green mark area, you end up in a greater deformity. So we want to prevent the seroma, so we started using quilting. That's one of my colleagues, Nitesh, present in the morning. So 5 stitches we take and we quilt the area. It will be okay for the grade 1 and grade 2, but grade 3 and grade 4, quilting 5 places, difficult to use the lifting plaster. So we use only these 3 places because these 3 places are the area usually we see the seromas in our practice. So we quilt only these 3 dotted areas. So once the seroma occurs, usually we do twice aspiration if seroma is still continuing to come because most of the difficult seromas happen only after the 7th day. So we do the aspiration, then we put a doxycycline injection, 100 mg doxy, and they'll come back one more time for the aspiration, that's it. After that, their seroma won't recur. 99% of the time, seroma will settle with the toxic. Other problem is the skin laxity. So we want to use some energy devices to correct it. So started using based on the last 2 years. It gives a better results. I don't want to use one more energy devices in the subdermal plane because we use pigment a lot. So using the radio frequency devices and doing the subdermal thing, I'm not much interested. So we use something called orgoplasma. It's a plasma energy. So usually the vertical scepter goes from the fascia to the skin. We tend to, this one tighten that part, so it's not a subdermal thing, it's basically this septae only adjusted directly. I think you can visualize it here. So, there are results in the orgoplasma. So the orgoplasma the skin tends to tighten for even 6 months. So the results, you need to wait for 6 months to see the complete results of this, the energy device. So this is a post of 1 year. So these are a few of the results. These are immediate post-op. If the skin quality is good or whatever you do, you get away with it. When the skin quality is bad, these are the things you need to do for sure. These are difficult cases. It's 1 month post-op. This is the case. So though he is ideal for the double incision mastectomy, but he doesn't want to go for double incision mastectomy, we did this. I'm not happy, but patient is happy. Thank you.